So Roger, thank you for that tour de force. I guess I'm asking, are you leaving us optimistic or pessimistic? I heard we did well in the past. I heard that our productivity is declining on an inflation-adjusted per dollar basis. But the question of how we are going to get to mechanism for the common diseases. It's easy to get to mechanism for the rare single gene disorders. Yeah. We know the gene, maybe gene therapies and other things will even make a kind of reproducible platform for all that. It seems to me that there was a time that we thought the Brown and Goldstein paradigm of LDL receptor was going to cut a hot knife through the butter of a complex disease. Doesn't look like it's that easy in most of these things.
Not so much.
Not so much. So we're going to actually have to grapple with how we take complex genetics and other kinds of physiological experiments and get to mechanism that's druggable. I mean, Alzheimer's, a fair argument is we might not be going after the right thing. We really might be better off in the microglia, for example, or
the microbiome.
Or the microbiome, or whatever.
Sure.
And so how do we get to a turn-the-crank-ish sort of paradigm that might allow us to get much more productive? And here I see the gap between the academic research, which is doing its part of peeling away the onion, and pharmaceutical and translational research, which takes different points of view, and they don't talk as much as they should to each other. So, there's an effort to make a consortium now, kind of the maps to mechanism kind of thing. What do you think is going to be the answer? Because I don't want you to leave us depressed about this.
Oh, yes, no, I hoped not to.
Then tell us the answer.
Yeah, so the answer, I'm afraid, is it's just going to take a lot of time. And those who hoped that there would be this dramatic acceleration as a result of the availability of complete genome sequences, I'm sorry, that's not actually going to make it happen. It does provide starting points for us, though, that are extremely helpful and in some cases have proved to be worthwhile. The example that I gave with immuno-oncology is in a way, proves the point that really, there was almost no one who believed that blocking these so-called inhibitory receptors on T lymphocytes, in fact, most people didn't believe that inhibitory receptors existed on T lymphocytes. There were relatively few people who did, and I give a lot of credit to Jim Allison for having continued to argue on behalf of this for many years as really a lone voice in the wilderness, like at the time when many others, including myself, felt that it was unlikely to be true. But he stayed with it, and ultimately it was tested correctly. And when that happened, the field opened up pretty dramatically, and we knew what to do thereafter. I think there are a lot of discoveries like that are waiting to be unearthed, and that we are in a better place than ever to prosecute those discoveries precisely because we have better measurement tools. One thing I can tell you, I can give you a lot of confidence on this, is that we can pursue a target. That we can do. And I was speaking with someone earlier about the strong right arm of industrial medicinal chemistry. We can drive to compounds which have extraordinary pharmaceutical properties, and we can test those things clinically. Our problem at this point is getting to a level of conviction with respect to the preclinical biology that enables us to say that is something we're going to test clinically. But I'm optimistic about that overall. I think our better measurements, ultimately, more data, better. That's my view. Yeah.
Are you aware of any interest in the pharmaceutical world of developing drugs to counteract or which in fact are absent of the profound effects on patients of withdrawal of those psychotropic medications?
There are organizations that are working on those kinds of things. I personally don't have any experience with it because we don't make any of those kinds of drugs. So we're not involved in that kind of research. But I know my colleagues at other companies have been involved with that. Again, one of the problems that we face, there's no harder area in which to work than the central nervous system.
Right.
Because we have relatively poor tools. The ability of a compound to impinge on just a few cells in the central nervous system is enough to have a pretty dramatic effect.
Right.
So it's just hard to measure, to get time-based measurements on what's happening. And in many cases, the reprogramming of the central nervous system that occurs because of exposure to pharmaceutical agonists or partial agonists can be quite profound. And how you would change that, we don't have a lot of insight into right now. But people are working on it.
Thank you.
James?
So I thought that was a really interesting talk, and I wanted to quiz you a little bit about yes, that's high praise for an English person. Wanted to ask you a bit more about the health economic aspects of it, which came up from time to time. So that I guess where we were left was that, well, there's a declining economic productivity in drug development. That's been going on for some time. Doesn't seem to be any sign that will let up. And I was thinking not just about private industry, but about governments as well, so that governments across the world are putting billions of dollars into basic science research in the hope that that will then later spin out into research that might lead to new drugs. I was wondering, well, are we putting some of our resources in the wrong place? It looked like there may be other things that governments could do much more cost effectively, which would have a bigger effect on population health.
Well,
if you're saying that basically the time of big new effective drugs that could have a game-changing effect on common diseases is past, then why are we doing this?
Yeah, well, so I don't think that the time has passed for drugs that can have game-changing effects on broad populations. I do think, though, and thank you for providing that question, I do think that governments have lost their way because they've decided that they want to participate in the exercise of trying to find drugs, something that they clearly are no good at. This would be an interesting discussion for Chris and I to have because he leads the National Center for Advanced Translational Sciences at NIH. To me, the fundamental problem is, as I explained it, that we have really no idea what normal physiology is all about, not at the organismal level, certainly not at the organ level, and certainly not at the cellular level. So since we don't know any of that stuff, it's very difficult to decide what's wrong in a patient with a particular disease or how to intervene. What I need more than anything else is more fundamental research. What I need is scientists who are actually doing the exploratory work of trying to understand biology. That's really very important. Instead, what's happened is that budgets, particularly in the United States, but elsewhere as well, have been shifted to more practical interventions, including, for example, very large clinical trial budgets that look at outcomes research over a long period of time. There is use in those things. I can't draw a hard line there, but I would say to the extent that that undercuts our ability to do fundamental research, I think that's a very big problem. And if what we want to do is create better medicines, which we can use to intervene after we've assembled information about individuals more precisely, then we need to have a better understanding of normal physiology.
Professor Dickinson?
Thank you very much. I found that very informative. I was very interested in your slide on the percentage of your profits which are now made from orphan drugs. And well, maybe I'm not putting it terribly well.
I'll get it.
I mean, the bar graph, I think you know what I'm referring to.
Yeah, sure.
Yeah, of your income. I presume that I'm struck by the parallel between that and the high pricing, because I'm presuming orphan drugs attract a fairly high price because they're for a niche market.
Have to, yeah.
So it's supply and demand.
Yeah.
I'm interested in the parallel between that and personalized medicine drugs, which also are aimed at niche markets, if they only cover a small percentage of those with the disease. In the UK, for example, we've recently, I'm sure you know this, had a decision not for the National Institute on Health and Clinical Excellence, not to fund a cystic fibrosis drug because it
Vertex.
comes in at 300,000 pounds, I think,
Yeah.
rather than dollars a year. So I'm just wondering whether, in the case of the niche markets created for personalized medicine drugs, is the industry also, and I hope this isn't a leading question, I'm just honestly interested in this parallel, is the fact of it being a niche market for such a drug similar to the situation with the orphan drugs?
Well, okay, so first of all, I don't think that precision medicine by itself necessarily means that the market will be niched, right? Precision medicine means only that we can define price quite precisely which people might benefit. That could be a lot of people. For example, if we take, again, the LDL cholesterol example, we could look at that example and say, this is the group of people, to Lee's point, this is the group of people for whom diet and exercise is just not going to do it because they have a genetic signature that says that won't work. And that population is actually quite large. And that population, if we didn't already have generic drugs that were quite effective, is a population that would clearly not be a niche population. The health economic situation is, as you describe it, that if you can have a big treatment effect in a small population and it's life-saving and you give it to patients very early on, typically as children, the health economic benefit can be argued quite strongly, and the price that one can gain in those areas, in those markets that have health technology assessment agencies, can be quite large. NICE's decision with respect to the Vertex cystic fibrosis drug has more to do with the set of patients who would benefit and the magnitude of benefit that they experience as a result of a drug that is incompletely effective. If we had a replacement drug that actually took out the defective cystic fibrosis gene and reintroduced an appropriate channel, then that would be a different story altogether, but that's not the drug that we have right at the moment. I think the hope has always been that the cost of developing drugs for niche markets, because you can do small studies, big treatment effects, patient populations that are very cooperative, sometimes funding from external agencies, that the cost would be much lower, and therefore you can get a return on your investment from those things much more easily. I can't vouch for the behavior of my colleagues in the industry, and some might choose to treat that as an opportunity to gain perhaps additional profit more than they require, but that's a job for HTAs to deal with and others. So I think there is a way forward for this, and over time I think it will be regulated appropriately.
Professor Ciechanover and Professor Hull.
Roger, since some of the considerations of the pharmaceutical companies have to do with money, either it's the large cost of development or the short-term life of the drug in the market, like antibiotics, maybe it's a crazy idea, but why not governments should interfere by either having their own companies or subsidizing companies, encouraging them to develop drugs? And, you know, the governments are funding education, they are funding defense, they are building hospitals and health systems. So what's the benefit of a hospital if you cannot provide an antibiotic to Pseudomonas aeruginosa? Sure. So how about this crazy idea about this cooperation between governments? Because part of our health is basically at the hands of private companies' shares, boards of directors, CEOs, and so on, which is somehow unacceptable.
Right. No, and governments are already doing exactly that. So, for example,
malaria, you know, that's on the other side of the world.
Well, no, but when you think about antibiotics and antibiotic stewardship, as an example, a qualified infectious disease product gains additional patent life. A variety of social engineering kinds of efforts go on the part of governments to encourage pharmaceutical companies to develop drugs for pediatric indications, as an example, which otherwise would not be acceptable markets. So there are those things already. What happens, as one of the few companies that still develops antimicrobials, what happens is we develop new antibiotics, and they're put behind armed guard in hospitals because, of course, nobody wants to use them. They're the last resort. and they don't want to take the risk that resistance will develop against those antibiotics. So as a commercial proposition, it's not worth very much. But nevertheless, I mean, over time, you can gain some meaningful return on that investment. And also, you can actually gain registration now with much smaller studies because of efforts on the part of regulatory agencies, not just FDA, but EMA and others, to enable that to happen. So those kinds of efforts are going on. I'm a little bit, I mean, there's no reason why governments can't pursue making new drugs. Many have. But I'm a little bit concerned about their ability to bring forward the set of skills necessary to do these kinds of jobs, and whether or not they can provide the appropriate incentives. Over time they may, but at the moment it would be very difficult.
Roger, I certainly agree with you on the big data could lead to interesting ideas. One of the things that academia has been pretty effective in doing is making their big data available to everybody. And I'm just wondering, what's your sense of what pharma is doing in that regard? Because they paid a lot of money to get the big data. Are there ways to be able to release it to people who can really begin converting data into mechanisms?
Yeah, I think that there are data transparency initiatives everywhere. Over time, I expect that those data will become more and more transparent. As background, the belief in pharmaceutical companies was for a long time that, my God, we paid for the clinical trial, we own the data. But that belief is moderating. Within the general confidentiality concerns of having appropriately anonymized data, certainly data at the aggregate level and now even single patient data are available to qualified investigators. They simply send us a note and we make it available. In fact, in many ways, we're much more permissive about that than most academic institutions are, where for reasons of careerism, academics would like to hold on to their data in order to be able to be the first to describe the correlation and analysis, and et cetera, which is not an issue for us. So we actually are pretty good about that. Our concern, I should mention to everyone, our concern is the signal to noise problem, which is if you have a lot of people who go out and analyze data, you have big data, you're going to find a lot of correlations. And there's no correction in typical analyses for multiple looks. There's no, the statistical basis in these post hoc analyses, they're not pre-specified. These are very problematic. And the controls that we built into these things for a whole variety of reasons related to the population that was recruited may not be adequate to answer the question that was asked. So you end up with a lot of stuff in the literature that people then pursue, which they really shouldn't be pursuing. I can't control that, really. I can't legislate high-quality research, but that is an issue.
You know, one more point just to support you. I remember the German government about 20 years ago put an enormous investment to the government setting up a whole series of biotech companies, and over a 10-year period, it turned out to be an unmitigated disaster, wasted an enormous amount of money, and it was all about expertise. And
yeah, it's very hard to find that the set of skills are to integrate across, from fundamental research through biostatistics, clinical trial execution, not to mention the engineering tasks associated with making new drugs. They're pretty hard.
Can I ask about making old drugs, not new drugs?
Yeah,
So I tend to agree with you that governments creating drug companies, not necessarily a very productive idea. Generic drugs. The idea, given what we've seen happen in generic drugs, I realize it wasn't part of your talk, but you're here to stand to answer all possible questions on the pharmaceutical industry.
Bring it on.
So
Go for it.
So what's your take about the idea that government might let firm fixed guaranteed contracts for generic drugs and have companies bid to supply at those prices, and maybe to such suppliers? That is, to have a far more regulated, organized effort to have generics produced in a predictable way.
Yeah. Whether that's the right answer
Or
or
something
not,
like
I don't
that.
know, but something clearly has to be done.
Yeah.
Because of the lack of profitability of generic drugs, nobody wants to make them. You really only gain back profit on those generic drugs in the first 6 months after launch. So the first company in the generic world can make their investment back, others cannot. And as a result, pretty soon you end up with a monopoly supplier of the generic drug, which may then get into trouble, often because of regulatory violations, and they're unable to manufacture to quality specifications. At that time, you have none of the drug available. We have our own experience with this right now with BCG. TICC BCG is a microbial agent, actually. It was used for a variety of purposes, but it's actually effective in non-muscle invasive bladder cancer. So you grow up the microorganism and you instill it in the bladder, and in individuals with non-muscle invasive bladder cancer, there's about a 70% response rate. It's quite impressive. It's extremely irritating and unpleasant. Nobody likes getting it, and they certainly don't like getting it repeatedly, but they prefer to get it than have invasive bladder cancer. There used to be two manufacturers, us and Sanofi. But Sanofi had a fungal contamination of their factory, and because they don't make any money on TICC BCG, they said, what the hell, we'll just close the factory, which left us in the situation that we have to supply the entire world's market. But our factory isn't big enough to supply the entire world's market. So we can't actually build a new factory to supply the rest of the world's market. It would take us 5 years to do it anyway, and it's not cost effective. And so when you look at that, it's just, you feel like, well, gee, there must be a better way to do it. We shouldn't have ended up in this situation anyway. That's just one example. There are so many. For those who practice oncology, it is a disaster when proven effective antineoplastic agents become unavailable because a generic supplier suddenly stops making it. And that's also the cause of some of these ridiculous situations, as when, for example, Martin Shkreli takes a rarely used antimicrobial agent and charges a ridiculous price for it by acquiring the single supplier that makes it. We can improve it. We can get better.
I thank you very much for a very stimulating talk, but we ought to be open for the whole afternoon. So I'll start with one comment or question to you, and then something to be open for the afternoon. If you go back to this line of decline in productivity, and one statement you made that maybe I a little disagree, at least for the discussion, that governments are bad at development. Can you go back to the slide of, no, it doesn't that matter. When there is a world war, governments, democratic governments, are very good in research developments in pharmaceuticals. And it's not a zero-sum game against the private sector. Many private companies with lots of money. And maybe there is something in the whole society, in England and the United States in particular, that allowed this surge, and we can reenact it without having another world war, of course. So the distance from the World War and the beginning of the Cold War might be another factor. Now,
Can I stop you there for a sec? Because those governments just gave money to pharmaceutical companies like mine to do our work.
But it was then and not now.
And it was for antimicrobials where there was a really cut and dried way of approaching them. So it's not really the same.
Now, about the regulation, I wish to address Professor Lander and all of you with a kind of thought experiment, a practical one, maybe a little provocative, but might be realistic. So we have this couple carrying some genetic mutation for a significant disease. And they say, give us germline editing and we have our children. And you say, no. So says, okay, we'll have our children and we test the embryo and we will abort it. We will have an abortion if the embryo is sick. If you don't give me germline editing, I will go on with having a child I test the embryo at 10 weeks, 14 weeks, and if the embryo is affected, I will abort the embryo.
No.
Wait.
Yeah.
If this is the trade-off, that might be, because at least in many countries where abortion is legal, the whole view on this moratorium might change. Certainly in 5 years, just a second, I will finish and then you'll answer. In 5 years, even the pro-lifers will not change the law. Okay.
So,
second, I will finish and then.
okay.
Second, the next step in the thought experiment, that we condemn this germline editing, but there's a rogue scientist who produces children, or a few children, minority, and they are being stigmatized and discriminated against. And we don't want this to happen, because all humans are created in the image of God. They deserve equal treatment. So, is it so severe or not so severe? What is the analogy? When society was motivated to prohibit extramarital sex, so they had a category of bastard children, and they were stigmatized legally, and now we don't want this to happen. So all children have equal standing in the law, and also social attitude of fornication is not that severe because we don't see anything different. So somebody may edit children, clone children, we would not like them to be stigmatized. As long as we don't see harm, we integrate them in society, and then people say, so what's wrong with it? Are we going to repeat the history of bastardy again when in the past bastards were those, the offsprings of illegal sex, whatever society considers to be? And now we will create a new kind of bastardy that is a result of illegal or immoral genetic or biomedical intervention in the embryo. And as much as the first category collapsed because we didn't want to stigmatize the children, the second category might not hold, even if there are reasons to hold it. These are the two.
Okay, great. The first, you are saying couples will choose to have the child and abort based on amniocentesis. No, but the choice is not that. The choice is in vitro fertilization and choosing which embryo to implant. As between those two choices, it's available. That's not germline editing. That's no editing. That's simply selection. It happens today. You can go down to the store and get it today. It's done in hospitals all over the world. So you're making, I think, a false assumption that what people will do is use abortion. They will use pre-implantation diagnostics, because I can't see anybody who would choose having the pregnancy and aborting it over doing in vitro fertilization. So I think the point is, there's a technology today that is much preferable, and where it's not used either because people didn't know they were at risk, or they couldn't afford it, or something like that, but that's how we should deal with it. So I think that one is not a real choice, and I'm happy it's not a choice, but it really is not a question of germline editing or not. The second, of stigma for children who have had editing. Well, we have these two baby girls in China, some of whom, and both of whom, carry mutations that have never before been seen in the human population, that were created for the first time. I have no idea what they do. Well, now how should you treat them? Should you treat them as victims of a crime? I think so. I think what Dr. Cho did is a crime, and these are children who were harmed by a crime. The same is probably, now, not criminal, but you think about somebody help me with the birth defect drug, thalidomide. With thalidomide, you have children who have, phocomelia due to thalidomide. They too are a victim, perhaps in that sense, of poor regulation or whatever. I don't know.
You will not stop them from having children.
Sorry?
They will grow up and wish to have children of their own.
Because we can't stop them. They have autonomy.
So in one track, having this mutation in a child is illegal, and in another drug, passing the same mutation to a child is legal. This is the trap.
Yes, yes, but one is an act by a physician or a clinic that was illegal. The other is the same as if you inherited a mutation. We don't stop people from having children because they inherited dwarfism, achondroplastic dwarfism. They may have children. They can even have dwarf children. Indeed, there are couples who choose to have dwarf children, and there are couples who have deafness who choose to have deaf children. I think that human autonomy is something worth preserving, even though it is true that the result is it might be the same result as if it was done intentionally and against the law. The world's complicated.
The last line. This is for the argument, for understanding.
Yeah.
If you protect human autonomy and encourage or allow people to have children with these genetic defects or whatever you call them, why would you block a scientist from having a child that may have something beneficial, may not? There is this imbalance here. Either it's a severe, just because it's the scientist in the natural way, where it lies. If from utilitarian way of speaking is the same, you need to compare one genetic outcome to the other.
So no. Why would I allow parents to make choices? Because I trust parents, because parents have an autonomy, as opposed to trusting someone who is peddling their unapproved therapy and has a commercial interest in doing so. Yes, I'm in favor of regulating those people who would prey on others. And I'm in favor of trusting parents to make loving choices. They won't make them right. Parents screw up their kids in amazing ways. But if I have to choose a world, I'm going to choose a world where I will trust the parents, and the self-interested person peddling this thing, I feel should go through FDA regulation and law. And I realize, that doesn't mean the outcomes are going to be right in either case, but I'm making choices about motivation and about how to organize the society. And I'd like that society better.
Professor Nicole and Professor Fins.
Thank you. I just wanted to say that I agree with the idea that the other option is PGD, and PGD will always be. PGD will always be a good, better option. I don't even buy the idea that germline editing is a replacement for PGD in some circumstances, because if you have a shortage of embryos, it probably is going to take more than one embryo to get an embryo that you would be happy to implant that has had genome editing. And you would do PGD on it to make sure that it actually has the mutation that you want. So in my view, germline editing will only be in those very remote circumstances where you've got a recessive disease and both parents are homozygous, or a dominant disease and one parent carries the mutation. So it is going to be, at most, in very rare circumstances.
So a question for Roger and more generally for the group. The issue of large data sets and mechanism and drug development. We talk a lot about the current, what it describes the United States, the valley of death. There's a proof of principle. Things are funded by the NIH as basic science. And then to capitalize it, you need either VC or industry support. And a lot of good ideas die on the vine in this valley of death. So I'm just wondering how an idea that starts in big data then has to go to hypothesis generation, developing mechanism before you say get a drug product, how that navigation changes. Will we create a second? Will we have two valleys of death? Will we have ameliorated the problem because we have a higher probability of effect because we've mined big data? How do you see this playing out vis-a-vis those generic obstacles?
Yeah, I think that the problem is you say that there are a lot of good ideas that die on the vine, and I don't think there are.
Or they're delayed.
I don't think there are. I think that there's a paucity of good ideas out there. There are a lot of really bad ideas that go into the clinic. But good ideas, no, they go. I mean, as it turns out, there are a lot of good ideas that go into the clinic and don't work. I mean, that happens a lot. I think what's going to happen as a result of these large data sets is that we're going to have much better validated ideas, and that's going to enable us to be more successful. Now, I caution you that we've been saying that for a long time as we've accumulated more data, but sometimes it's right. Yeah.
We have Professor Boniolo, Reardon, Prince, and Mohazam.
Very interesting talks. I have two questions. Oh, there isn't. I have a question for Roger and one for the passionate Eric. For Roger, I wonder this, when you do drug discovery, you start from a molecular mechanism which should be reliable, which should be controlled, and so on and so forth. Do you think that this decline in the production of the new drug also has to do with the so-called reproducibility crisis? That is, you know that there are a lot of paper in top journal concerning this reproducibility, and has this to do, is one of the causes of this, and concerning to Eric, when we speak about reproductive choices, actually we are not speaking only about with whom to have a child, but actually there is a spectrum. There is a possibility, for example, and we have to decide, or the society has to decide where to put the threshold. Think about the Nazi period in Germany or the fascist period in Italy. In Germany, there was it was compulsory to have a reproduction with an Aryan, that is the mother and the father to be Aryan. In Italy, is the same, and so the reproductive choice was stopped by a decision from the government, in that case, the dictatorial government. And there could be the possibility to have the choice, for example, two dwarfs could decide to have a dwarf child, two deaf could decide to have a deaf child. And probably there is no one that say, no, you couldn't, otherwise you should be in the Nazi German or in the fascist Italy. And the same argument as proposed by Michael. And why two parents couldn't decide to have an earthly child if they know that both of them had an hereditary mutation? And why couldn't they try to use this new editing technology in order to have an earthly child and an earthly nephew and an earthly grandnephew, and so on and so on. That is, the problem is not just yes or not, but to consider the reproductive choices in all its complexity and then decide. And the problem, again, is the same as before. Who decides? The government, the citizens, the wise men, the technicians, the scientists, the priests. Who decide?
So first of all, thank you, Giovanni. For it is a problem that we see more and more publications, the results of which are not reproducible when studied by others, and there are a variety of causes. Certainly that contributes, but I think it contributes a relatively small amount to the challenge that we face of spending more and more money and getting fewer and fewer drugs out. It relates to this issue of there being not that many high-quality ideas out there, but the reality is that the cost, both the direct cost and the opportunity cost of doing fundamental research is relatively modest compared to the enormous cost associated with doing reliable phase 2 and phase 3 clinical trials that end up not yielding a satisfactory result. So I think that it has an effect, but probably not the major effect.
So with regard to your question about having healthy children, I think couples should have the ability to have healthy children. But they do already. So when a couple is, say, carriers for cystic fibrosis, 75% of the embryos are unaffected. They can use PGD and select those. If you cannot use PGD. It's not allowed in Italy? Sorry, or in Germany? Oh, so then there's another question. So this raises the interesting question. I'm worried about germline editing, but you're saying in Italy and Germany, you can't do embryo selection. You can in Germany, but not in Italy? Okay, well then that's a question to talk about. If you can't do it, if I had to choose between going in and trying to edit the genome or selecting which embryo to implant, remember to edit the genome, I start by taking out embryos, I look at them in vitro.
Eric, my problem is not what we can do from a technical point of view, but who decide? Who should decide? Who is in charge?
Well,
the citizens, the government, the politics, the parliament, the priest, the rabbi, who?
So do we mean who? It depends on who should, the meaning of who should decide. If you mean who has the right to decide, governments have the right to decide. They can pass laws. Who should decide? Well, I think a negative choice by a government that you may not marry this person who's of Jewish descent is wrong. They may have the right to do it, but it's just wrong. I think governments forbidding you from making your choice of who to marry is wrong. I think governments regulating technology is a different matter. So, you know, it's really a question of what are you asking? On the whole, if I have to make my choices, I will go with the couple more often than with the government telling them what to do. If it is, you know, one of these choices about who to marry, if I were to allow
Eric,
it, you know,
would you mind if I interrupt?
Yeah, please.
On my left, please.
Dr. Bruce, no, I just need to just make a point, because there are lots of people with their hands up, so we should try and avoid this becoming a discussion between two people. Because there are other people who want to make, I don't know if you want to make a point on the current discussion, I certainly do.
Please go ahead.
So that was just a point of order. We need to make sure that doesn't happen. So on the issue, again, of the choices and who makes the choice. So Eric, you talked about the autonomy of parents, you know, and they're loving parents and, you know, they will raise their children. I think you have to think of it a little bit deeper. The autonomy of the parents to decide entirely, is that absolute? I come from a part of the world where parents decide not to have female children. So therefore, when we talk of autonomy at an abstract level, I always have issues with that, because is somebody who lives and is part of society really autonomous the way philosophers describe that concept? My argument is that they're not. And so we have to be careful when we talk about, from where I'm coming, about the autonomy of parents is always the right.
I agree. I tried to state the autonomy as relative to this person who is peddling this genetic technology. But I said, on the whole, I favor the autonomy of parents. I agree with you. It is not an absolute autonomy. Parents can do things that are a little wrong and a lot wrong. And I agree with regard to sex selection and abortion for sex. I'm completely with you. So none of it is absolute. On the whole, I'll take the parents over in an IVF clinic trying to sell something, but it's not absolute at all. You are absolutely, or I completely agree with you.
Jenny and Barbara. Please, between the two of you.
I have one comment about this conversation, and then I have a question for you, but I can just put this at the end and we can return to it. I think it's not, the difference is not between the autonomy of the parents on the one hand and the meddling scientist who was trying some unproven treatment on the other. I think it's a difference between an intentional, directed intervention to manipulate, in the widest sense of the word, a specific trait on the one hand, and something that does not try to manipulate a specific trait on the other. And here I agree with Yechiel. We cannot just assume that whatever nature is doing is a priori better than what we are doing artificially. Otherwise, we end up with some kind of nature exceptionalism that is problematic in itself. But I think trying to manipulate a specific trait or not is the relevant difference. And I think for anything and anyone who tries to manipulate a specific trait, the threshold to do so should be very high. So that was my comment, my question, and again, I'm happy for this to be returned to later on, would be for Roger, because the analysis, I think, was very enlightening in many ways, but I was not so sure that I understood what your message would be, your takeaway points of what should be done to address the problems that you described, other than bailing out pharmaceutical companies.
Yeah, right. Right. Well, I think that the first thing which came up in our discussion from Professor Wilson's question is that governments ought to focus on what they can really do well, which is to fund fundamental research. And in funding fundamental research, which includes research that addresses the kinds of issues that Lee talked about and that Eric has certainly been involved in, we will get a much deeper understanding of human biology and will become more successful over time. The second thing is that in reality, other than the kinds of regulatory mechanisms that we were talking about for generic drugs, ultimately corporate investment will follow better ideas. Ultimately that will happen. And while our productivity will decline for some time, eventually it will come back, and I have a lot of confidence. I've always said that I have confidence that if companies succeed in identifying drugs that actually improve and extend life, society will figure out how to pay for those things. I have confidence in that, and ultimately that's enough of a draw to, I think, encourage investment for some time.
Professor Reardon and Professor Legato.
I'd like to ask a mundane question. What is the impact of the powerful ability, or the ability of powerful insurance companies to back a drug, usually a generic drug? What impact is that having on the impulse or the wish to develop new products at great cost in the pharmaceutical world?
I think you'll get many different responses to that question, but my general view is that generics are a force for good. Generics should be favored. They provide headroom for us. If we discover something that's better, then there's the ability to pay for it. If people are still spending a lot of money on drugs when there are generics available, then there's no headroom. So I accept the challenge. My responsibility is to build better medicines. My responsibility is to make things that are better than what we have now. And if we can't do that, then we should go out of business. That's my feeling.
Professor Jenny Reardon and Von Braun.
Okay, yeah, so I'll go back to what my question was originally, which is kind of picking up what James Wilson had said and what Barbara Prainsack has been saying, which listening to your talk, I found myself, and going back to Eric's point, struggling to understand where the optimism was. And which makes me really appreciate having this setting, because I do think we need to think together about what the big picture is, because it seems like there are some big problems with the big picture. And so my question partly is sort of like everybody's been asking you, you know, sort of like we're looking to you, like what's the answer? Like what should we do? I'm not sure that's the right question, because what I'm hearing from you is, one, we need fundamental new knowledge, but I'm not actually sure and clear myself what counts as that. Like I'm a little unclear from the discussion whether or not big data is part of your vision of what that is, or whether or not you would suggest some completely different paradigm to pursue. And maybe the big data route, we've been hearing it for now, you know, every 5 years we're told in 5 years this will pan out, but we've been hearing that now for 25 years. So maybe we actually need a new paradigm. We're not in the middle of a paradigm shift, but we need a new paradigm shift. But I'm not sure. I'm just like listening to people and trying to make sense, but I really appreciate the Academy providing the space, because I think it's deeply needed, because we're spending billions of dollars and what are we getting? I mean, I guess that's the question that you're raising too, right? And I think that's the question the public is raising. And when we think about why there's vaccine, and I wanted to ask you about this, I'm curious your theory about why we have vaccine deniers. My own sense of that, I'll just tell you my answer to that, which is that I think there's a declining trust in the pharmaceutical industry. And when you have declining trust, you produce things that look irrational. But the sources of the declining trust may be rational. So I guess partly it's a comment. I have two specific questions. One is, what do you mean by basic knowledge, and what would you actually fund? If you were the head of NIH, where would your next 5-year budget take you? What would you cut? I want to hear what you would cut, actually. And what would you fund? I guess that would be my question. I'll hold the vaccine denier question for another point.
Well, I mean, I think that I won't take the challenge of resolving the $35 billion NIH budget right now, but we can take that offline. There are many pieces to it. So, yeah, there will be plenty of opinions around the table, but I think we probably would be mainly in agreement because we all come from the same background and we probably have the same sorts of ideas about how that money could be invested best. But not dodging that question for a minute. It is true, of course, that we have been saying for years that we need additional resources for discovery research funded by the federal government in order to produce these benefits. It's also true that despite the declining productivity of the pharmaceutical industry, we've benefited a lot. And I tried to show you what some of those benefits have been, and those benefits are continuing now in areas that we weren't approaching before, neoplastic disease being one example. So, oh, woe is me. It is, unfortunate that companies are finding it more difficult, but we manage. Okay, so I don't, I appreciate the concern, but that's not really the issue. We'll get there. It is much more difficult than before, and society pays the price of that in terms of the cost of medicines too. There's no doubt about that. But nevertheless, by and large, we're finding our way there. As to the causes of vaccine hesitancy, as it's called, there are many, but I think the largest issue, and it's a very big issue, is the lack of trust generally, not just in the pharmaceutical industry, but in experts, right? So people no longer believe in expertise, and that's true around the world, and we're seeing more and more of what's called populism, but I see it as something else. And part of that populism is that it challenges knowledge, and it challenges expertise, so that someone can come forward with a claim that a vaccine, for example, causes autism, which is widely discredited by a huge number of studies that have clearly demonstrated that it's not, that the Wakefield publication in Lancet, which has since been withdrawn, was not correct, it was fabricated, et cetera, but people, still cling to that idea, in part because we don't know what underlies autism. People want an explanation. They believe that technology is at fault, and that spreads dramatically through a lot of communities, in places where you'd be very surprised that it does. Very surprised. So, you see it in Santa Cruz. Yeah.
Von Brown.
Maybe, Roger, you could reflect a bit on the matrix of success of investment in precision medicine and personalized medicine. Wouldn't productivity measures require to look at outcomes in terms of DALYs changed or longevity changed, subject to or controlled for other environmental factors, rather than just looking disease by disease? So I, of course, from a corporate perspective, costs and returns matter, but from a societal perspective, they don't. It is the metric would have to be returns in terms of the physical type of progress in society, so happiness, longevity, DALYs, per unit of investment. How do you see the matrix which we should look at when we assess progress made with personalized or precision medicine?
Well, thank you for the question. I think to my mind, it isn't that difficult in the first instance. Survival is a pretty easy outcome to measure. The only problem with it is that it takes a long time. But overall survival for diseased individuals is the gold standard that we use. And ultimately, we have to justify to health technology assessment agencies that what we're doing is worthwhile on some societal metric. And usually, overall survival is the thing that we get to. Where we don't have overall survival, we use a method, and again, this was pioneered by Michael Rollins and Nice, which is quality-adjusted life years. Some measure societally agreed upon of an integral of well-being and the quality of life. Those things can be very hard to measure if you're having small treatment effects that last for a very long time. Ultimately, I think society's interests are pretty well aligned with ours when we are dealing with grievous illness, and I always want to focus on grievous illness. They're less aligned if you start talking about, for example, cosmeceuticals, those things that are designed to improve appearance in some way or some other aspect of performance. That's a bigger challenge, but the matrix is not so difficult when you focus on those things that have life-threatening effects.
The curve which you showed was not having an outcome.
It was only new chemical entities as a
Yes.
measure of a productivity of the industry.
That's what I was driving at.
Yes.
I think the critical aspect would be to look at what happened not only to that declining curve, but what happened to the outcome behind it. And that, as you just a moment ago said, could have still developed in a very efficient and effective way upwards per past investment in
In some ways, I think the fact that you're seeing the new molecular entities become dominated by orphan and super orphan drugs is telling you the answer to your question. Because from a societal perspective, if you're looking at overall society, greatest good for greatest number, those have a modest effect, and the return to society on that investment is small. And since the majority of drugs in 2018 were addressed at those small niche populations, probably not so good.
Shlomo Cohen and James Wilson.
I also have two questions to two different people, and if we have no time for that, then I'll just ask, and then perhaps we can get the answers later. One is to Eric, and it's a naive question just to understand the science in order to have information to make decisions. So you clearly favor IVF plus PGD. My question is whether there is a feasibility of in vivo gene editing, and if there is or there will be, will that change the balance between, because extracting, of course, the ova has its problems and so on. So that's one question. The second question is to Barbara, and the idea of taxing the mining of information. Perhaps I totally didn't understand what you were referring to, but if I did, then it's just a pretty mind-boggling idea. I never thought about it, so I'm interested in how to start thinking about it. And then this question, well, probably taxing only for-profit mining of data, and if so, then who exactly? I mean, like it's much broader than the medical world, right? I mean, advertising obviously is mining data, but it's just that data is so out there, like air, and we don't tax air. So I'm just interested in how to start thinking about this idea.
Answer to the question. Right now, no, but could one conceive of a virus that you could use to infect an embryo so every cell was edited accurately? Possible. It seems at the moment far off, but that's why I think this is a long-term problem, because the technologies will change. People are thinking about also taking out germ cells and growing pre-sperm cells and modifying them. So there's a lot of creativity, which means there's going to be a whole series of questions to be asked. So at the moment, it's not on the table, but science fiction has a way of showing up at a remarkably faster pace than you might think. So.
Yeah, so I totally get where you're coming from, I think, Shlomo. The basic idea, and as I mentioned, I'm not wedded to the idea of a data tax. I understand that it would be very difficult to operationalize it, but the starting point is data are not like air, because they are not naturally occurring. Somebody has curated them, somebody has created the infrastructures, platforms to where they are stored, where they're collected, where they're analyzed. And the idea of various people, I'm not the only one, who are thinking of data taxes is to acknowledge the public and personal investments in the widest sense of the word, investments of effort, investments of money, investments of time, of people and of publics that have enabled the creation of those data sets that are then used for various purposes. They are sometimes used for purposes that clearly have public value. And they are also used for purposes that are mostly carried out to increase profit margins, which is not necessarily a problem. But the current situation where some corporations that are utilizing data to increase their own profits without giving anything back is not tenable. So that is the starting point. A data tax, as I mentioned in my talk, or I was sort of rushing through, so I apologize if that wasn't very clear, would be very difficult to operationalize because you would need to, what I talked about in terms of tracking data use, means that we would need to make visible how data are used by different corporate entities. So there are huge problems related to that. The main one, which I haven't actually mentioned, this sort of shoots a hole into my own argument, is that it's very likely that the corporations who now employ the legal teams to avoid and evade tax would then employ the legal teams to argue that this is all in the public interest. So there are huge problems around it, but I think it shouldn't prevent us from thinking about how some of those profits can come back into the public domain in whatever form. So if you have ideas, I'd love to hear them.
Thanks. I think this is a comment on the debate between Professor von Braun and Ron Perlmutter. So I was thinking a bit more deeply about almost sort of what the right measure should be for sort of pharmaceutical productivity. And the worry seemed to be if you measure it in terms of new chemical entities, then it seems like so long as you can get a patent on something, bring a drug to market, then, well, you've got productivity in that particular sense, but there may be no particular social value in that. And so one of the worries over the last 15, 20 years has been the rise of so-called Me Too drugs, where there's an additional value, but it's not supposed to be that enormous relative, for example, to the available statin. Already you may have come up with a statin that's somewhat more effective, but only marginally so. And a lot of this is going to turn on what sort of health systems you're going to be deploying those new drugs into, so that within the NHS in England, you have the NICE, which is supposed to look at the cost effectiveness of new indications, and that when people have crunched the data over the last 15 years or so, it turns out that the vast majority of the time when they agree a new drug to be produced, it actually makes the system as a whole less efficient, so that within our health system as a whole, it costs about £13,000 a year, sorry, £13,000 per QALY. As you put in an extra £13,000, you get an extra year of quality life out of it. But nearly all the drugs that are approved are actually considerably less cost-effective than that, leaving on one side the very expensive rare drugs. And so that nearly every time new drugs come into the system, it turns out people are suffering and dying as a result of that. That may be a little bit strong, but if you follow the failed economic
there's no doubt that public health measures properly implemented have the greatest benefit, period. No doubt. And that there is no system on earth, there is no government on earth that mounts a satisfactory healthcare system or that can afford to pay for the one that it has. I mean, that's just true. So sorry, I mean, that's like world peace. I can't solve that problem for you. That is a really big problem. And that is the most cost-effective thing that you can do, period. That's better than anything else, anything that I could come up with.
The worry does seem to be that these new drugs are competing with public health.
And I don't disagree with you. I don't disagree with you. I think that is absolutely true. Of course it is.
One of the issues I worry about with paying for data is, what are you paying for? What we've just heard is you can gather big data, and it's going to go through 5 filtrations before you get to something that is useful. So how do you parse the value along the way and the value that's been input in converting data into actionable possibilities? I think there must be a better way of approaching it than thinking about taxing data. I just don't see how you can make the connections.
I hope there's a better way, because taxing data with data use, I'm not talking about taxing data, and that's not a trivial difference, that's an important difference. We are used from the paper age to think in terms of the buckets of data. There are the sensitive ones, there are the personalized ones, and the personal ones, and the non-personal ones, and so on. I'm talking about taxing data use. So the ideas that are floating around at the moment are not actually valuing and paying for outcomes, so what has been achieved with those data, but for actual use. So whenever they are employed, that would be taxed. It's like once it goes through the machineries of whatever infrastructures and platforms there are huge problems related to that as well. So I hope that there's a better way of bringing
if
people
1% of the time you get to something useful, you'll tax the 99% of the attempts that didn't go anywhere?
Well, only in the current ideas, and then I will stop, only when there is no public interest in the data use itself. And here's, of course, where we have another huge a battery of problems how to operationalize the public interest. But the idea is never that, disease research would be taxed for using data, or if I'm using data myself on my laptop, I would be taxed. So the idea is really corporate data use that does not have that does not aim at creating public value. I'm not saying that's the perfect solution, and I'm not saying it would be easy.
To conclude with a short comment, that a lesson I think to take is to be aware of the social and legal context that exists. I mean, Rappaport project that Dr. Hood presented now would be illegal in Israel, not because there's any law against P4, but the law on genetic testing had been enacted many, many years ago. But that's a fact. And my thought experiment illustrated what may happen if we introduce a ban on germline editing in Italy, where PGD is not a possibility, and we have to keep it in mind. And we also have to think of a very poor society like India, when you cannot live with modern infertility treatment close to you. So PGD is not an option. Early testing is not an option. Only makeshift quasi-charlatan ultrasound is an option. But if somebody is known to be a carrier of significant disease, he or she can still afford one trip to the West and have germline therapy that hopefully may knock off for many generations that cannot do PGD every time. So these things should be kept in mind as well, especially when you try to globalize a policy. Thank you very much for the first day. There should be dinner, no? Or if we don't behave well, there's no dinner. You send messages to the team, depending on the quality, how much grana to put.